Hi, I'm Danielle Wissman, and my DMP project focused on stress and anxiety among nursing students. This project really came from seeing how much nursing students are balancing between classes, exams, clinicals, work, family responsibilities, and everything else happening in their lives. I wanted to see whether a brief wellness intervention could realistically be incorporated into a nursing program and whether students responding after the intervention would report lower anxiety and perceived stress scores. I completed this project with guidance from my faculty mentor, Dr. Teresa Gallicatos. The project took place in a Midwestern community college nursing program and included students from both LPN and RN cohorts. That setting was important because I wanted the intervention to be something that could actually fit into an existing nursery program without creating another major burden for students or faculty. The practice gap was really something we see regularly in nursing education. Students are balancing exams, checkoffs, clinical preparation, assignments, work, and family responsibilities, and all of that can contribute to stress and anxiety. Those stressors can affect things like sleep, concentration, confidence, coping, and learning. So the goal was to give students a structured opportunity to learn and practice wellness strategies in a way that was simple, accessible, and realistic within the academic setting. My aim was to evaluate whether the wellness session was associated with lower group anxiety and perceived stress scores afterwards. I used the GAD-7 to measure anxiety symptoms and the PSS-10 to measure perceived stress. Basically, I wanted to know whether students responding after the intervention reported lower scores than students responding before the intervention. The group level wording is important because the surveys were anonymous, so I couldn't match individual students from pre-intervention to post-intervention. When I reviewed the literature, there was good support for addressing stress and anxiety in nursing students. The evidence supported several approaches, including mindfulness, stress management, and coping strategies, but there wasn't one single strategy that clearly worked for everyone. That shaped my intervention because I wanted to give students several realistic options rather than one prescribed method. The idea was to let students try different approaches and determine what fit best into their own lives. I used the Model for Improvement and PDSA to guide the project. I liked this framework because it kept the project practical. The questions were really, what are we trying to accomplish? How will we know whether we saw a difference? And what change are we actually testing? The change was the structured wellness session, and the GAD-7 and PSS-10 gave me a way to compare group scores before and after the intervention. I used a quantitative pre-test, post-test quality improvement design. Eligible participants were LPN and RN nursing students who were 18 or older. Participation in data collection was voluntary. The surveys were anonymous and results were reported in aggregate. Protecting privacy was important because I was asking students about anxiety and stress. The trade-off was that I could not link one student's pre-intervention survey to that same student's post-intervention survey. The project was implemented using the approved methodology and procedures. The intervention was delivered in person across 4 cohorts. Students completed the GAD-7 and PSS-10 before the wellness session and again after the follow-up period. They also had an activity calendar during that period, and the calendar information and survey data were entered into Excel. The planned Mann-Whitney analysis was used for the outcome data, so the methodology, intervention, data collection, and analysis followed the approved project plan. The intervention itself was a structured wellness session where we discussed and practiced several different wellness strategies. That included mindfulness and breathing, coping strategies, sleep, nutrition, exercise, time management, digital detox, gratitude, aromatherapy, and available mental health resources. Students also used an activity calendar during the follow-up period to record the strategies they tried. I collected and recorded those calendar data in Excel, but they were not included in the statistical analysis of the GAD-7 and PSS-10 outcomes. So the calendar supported the intervention and documented strategy use, but I did not use it to determine whether a specific strategy caused lower scores. Implementation was pretty straightforward. I completed the preparation and approvals, collected the baseline GAD-7 and PSS-10 surveys, delivered the wellness session, and then students had approximately 2 to 4 weeks to use the strategies. I returned for the follow-up surveys and calendar collection, entered the data, and completed the analysis. Because the follow-up period was short, this project only evaluated short-term outcomes. I did not assess whether the effects were sustained beyond that 2 to 4 week period. There were 168 eligible students. I received 149 pre-intervention responses, which was about an 89% response rate, and 153 post-intervention responses, which was about a 91% response rate. So altogether, I had 302 survey observations, but that does not mean I had 302 individual students. Many of the same students likely completed both surveys. Because the surveys were anonymous, I don't know exactly how much overlap there was. There were also no incomplete instruments excluded. For the analysis, I used the Mann-Whitney U-test as planned to compare the pre-intervention and post-intervention GAD-7 and PSS-10 score distributions. I also calculated effect sizes. One important limitation here is that anonymous and unpaired does not necessarily mean the observations were completely independent. Many of the same students likely responded at both time points, so some of the observations were probably partially repeated. Because I couldn't identify that overlap, the statistical independence assumption may not have been fully met, and that is important when interpreting the results. Looking at the descriptive results, you can see that the post-intervention group had lower average scores for both anxiety and perceived stress. The difference was about 1.8 points for anxiety and 2.1 points for perceived stress. These are group level differences though, so I can't say that individual students improved because I couldn't pair the responses. What I can say is that post-intervention respondents reported lower anxiety and perceived stress scores than pre-intervention respondents. When I statistically tested those differences, both were statistically significant. The p-value was 0.001 for perceived stress and 0.004 for anxiety. The effect sizes were small for both outcomes. So for the most accurate interpretation is that post-intervention respondents reported statistically significantly lower anxiety and perceived stress scores than pre-intervention respondents, but the differences were small. I also can't call these differences clinically meaningful because I did not have a validated threshold showing that differences of this size were clinically important. There are several limitations that are important when interpreting these findings. First, because the surveys were anonymous, I couldn't perform paired analysis or directly measure individual change. Also, many of the same students likely completed both surveys, so the statistical independence assumption may not have been fully met. I also combined the 2 LPN and 2 RN cohorts for analysis, so I can't determine whether there was differences between the individual cohorts or between LPN and RN students. There was no control group or randomization, and I did not formally analyze adherence, satisfaction, or retention outcomes. And because follow-up only lasted a few weeks, sustained effects beyond that period weren't assessed. Even with those limitations, the intervention was feasible to implement within the nursing program. Post-intervention respondents reported statistically significantly lower anxiety and perceived stress scores, although the differences in effect sizes were small. If I completed another improvement cycle, I would use confidential participant-generated codes so I could pair pre- and post-intervention responses without identifying students. I would also formally measure strategy use and satisfaction, analyze the cohorts separately, and extend the follow-up period. That would answer several questions this first project couldn't answer. For me, the bigger implication is that wellness can be incorporated into nursing education as part of professional preparation. We expect nurses to manage stress, communicate effectively, think clearly under pressure, and recognize when they need help. This project doesn't show that one wellness session changes retention, patient outcomes, clinical errors, or long-term resilience, because I didn't measure those outcomes. What it does show is that a low-cost wellness intervention can realistically be incorporated into an existing nursing program and evaluated. Overall, this project took a problem I was seeing in nursing education and moved it through the quality improvement process. I reviewed the evidence, developed and implemented the intervention, collected and analyzed the data, and then looked at what the results actually supported. The main finding was that post-intervention respondents reported statistically significantly lower anxiety and perceived stress scores than pre-intervention respondents, although the effect sizes were small. Because of the anonymous design and likely overlap between respondents, I can't say that individual students improved or that the intervention caused those differences. If I repeated the project, I would strengthen the design with confidential matching codes, better adherence measurement, cohort level analysis, and longer follow-up. Probably the biggest thing I learned through the DMP process is that quality improvement isn't about trying to make the results sound bigger than they are. It's about looking at what the data actually shows, recognizing the limitations, and using what you learn to make the next improvement cycle stronger. These final slides contain the references that supported the evidence, measurement tools, statistical analysis, and quality improvement framework used throughout my project. Thank you.